So I'm Dr. Madeline Feldman. I'm a rheumatologist practicing in New Orleans, and I've been lecturing predominantly on PBMs since 2016. And I have Nilsa Cruz and Julie Bach with me. They are fierce advocates for patients with rheumatoid arthritis, psoriatic arthritis, and all of the rheumatologic diseases. Milwaukee and St. Louis, and I'm right here in New Orleans. So thank you again for having us. So the bottom line is I just stepped down as president of the Coalition of State Rheumatology Organizations, and we've been working for patient advocacy and access to medication for years. And one of our most recent projects is to help self-insured employers understand how to build a health plan that doesn't break the bank but takes care of their employees. So that's basically why we're here. So we're going to talk about self-insured employers, the issues, what's the responsibility of the employer, and how can we help the employees. And we have here potential solutions, but it's probably more just suggestions. In this area, there are no easy answers, and I would like to think that we're going to give you some easy answers, but I think there's something a little bit more that we have to take a look at. So why are we talking about self-insured employers? Well, as you can see, the darker the green, the higher the percentage of private sector enrollees. So it's greater than 50% in most of the country until you go all the way out west. So this is a really large problem. We have a lot of patients who are in self-insured plans, and sometimes it's very difficult to get them the kind of care we need to give them. So CSRO has put together an employer toolkit, and I'm borrowing from some of that for some of our slides here. So most of you probably are aware of this, but employer-funded health plans are not under the jurisdiction of the state. So we've helped pass a lot of copay accumulator bans. Yay, 19 states have banned them. PBM reform, step therapy reform, but unfortunately, self-insured employers don't have to pay any attention to those laws. They're under the Department of Labor, the ERISA. But ERISA has some particular rules, and I think we're going to take advantage of some of those in that they have to look after the well-being of their employees and the plan. It's called their fiduciary duty. And there's been a few lawsuits. Elevance has been sued, Blue Cross Blue Shield of Massachusetts had been sued. There's a couple others that have been sued by unions that are utilizing the Consolidated Appropriations Act of 2021 to get granular data, and they're suing when they can't get that from the payer. And that's part of what we're going to be talking about today as a way of employers understanding the cost, the true cost. Not necessarily the cost to the payer, but the cost to them and the cost to their employees when the wrong drug is mandated. So some of the issues that are affecting the plan and the beneficiaries we're going to be talking about. I've been speaking for a long time on formulary construction. Formulary, as you know, is the list of drugs the insurance company will pay for. And that is at the heart of some of the problems that we have as rheumatologists in getting the right drug for our patient. Higher priced drugs are often chosen over lower priced drugs, and that's fine unless you're the person paying for the drug. White bagging, Nilsa is going to be talking about white bagging. That has been a thorn in the side of a number of practices. Many practices like to get the drug directly from the specialty pharmacy, but others have infusion centers and are buying and billing and do not have the wherewithal of taking white bagging. And Nilsa will be talking about that. Accumulators and maximizers, Julie's going to handle that. The Office of Personnel Management from the federal government put out their plan suggestions for the federal health benefits. In their statement, they said, don't even bother sending us a proposal that has an accumulator or a maximizer in it for federal employees, because it is not in their welfare. So if it's not in the welfare for federal employees, why is it in the welfare for anyone else in the United States? And then alternative funders. Tomorrow, Julie and Nilsa are going to be doing a couple of roundtables, 3, I think, to be exact, at 11 o'clock on alternative funders. So we're basically going to tell you what they are. And then I'm going to close out with the conflicted consultant. So let's get started right away on talking about the specialty drugs. For self-insured employers, about 1 to 2% of their employees are responsible for 40 or 50% of the plan costs. And most of that is specialty meds. So that's why specialty meds get all of the focus these days. And at the end of the day, it appears as though, I've had this on good authority from Paul Holmes, who's an ERISA attorney for self-insured employers, that overall employers probably spend 30 to 40% more than they should. In many cases, the wool has been pulled over their eyes in terms of the actual cost of drugs, and certain drugs that are excluded that maybe actually are less expensive. One thing in terms of formulary construction, if an expensive drug isn't on the formulary, I don't care how great it is. If you're a manufacturer, you know this. No one's going to take your drug unless you give it away for free. So getting on the formulary is key. And how do they get on the formulary? Well, the pharmacy benefit managers construct the formulary. Long ago, when drugs started getting more expensive and the medical side didn't want to fool with the pharmacy claims, pharmacy benefit managers came into existence, and they're needed to actually adjudicate the claims and make sure that the insurance covers it. But because it's so important for these expensive drugs to get on the formulary, there's a bidding war that takes place. And it's a combination of a formulary rebate and fees, a total package of price concession. And as we learned in basic algebra, you know, when you have what we have here, any increase in any one of those variables will increase, let's just say, the chances of that drug getting onto the formulary. So you have your list price. So if I have a drug that's $1,000 a month and I'm promising a 50% rebate for every script that's filled, and the other company has a $2,000 a month drug, and they're promising 50% for every script that's filled, which one has the higher bid? $2,000 a month. But if you're a self-insured employer and you're paying the bill, you'd probably rather see the $1,000 a month. And I'm going to give you an example of that. So I testify before Congress. I testify before state legislatures on various kinds of predominantly PBM reform. And the one thing I keep hearing over and over is we need more competition. If we had more competition among the manufacturers, we could bring down the prices of drugs. How many people have heard that? We need more competition. Right. So what happens with price when we have competition? So if you're building a house and no one is your sister's brother's friend, and the quality is all the same, the competition to get the contract to build the house brings the price down. And the lowest bid, if everything else is equal, so yes, competition does bring the price down. But if you're selling your house, and you've got that one house on the block that everybody wants, what happens? The price of your house goes up. And that's what happens when you have competition based on the highest price, not the lowest price. And unfortunately, our formulary construction system follows under that particular result of competition. So this creates a perverse incentive for higher priced drugs, and you know, on the fully funded insurance side, that may be okay. But if I'm an employer and I'm actually paying for the drug for my employees, even if I get a rebate, I'd much rather have a lower price drug. And the way our formularies are constructed these days doesn't always happen that way. And if there's not enough market share for one drug, as we found out a year or so ago, basically entire groups of patients can be non-medically switched to another drug. That happened with a couple of blood thinners a few years ago. So let's take an example. If you're an employer, which drug has the best bid? And these list price are about, we don't really know what the list price is, but for 3 drugs that treat rheumatoid arthritis. And they all have the same mechanism of action. That part's true. The middle line I've made up. So we have drug A that's $30,000, one that's $65,000, and one that's around $75,000. And the rebates, let's pretend they're all going to be 50%. So we see the savings, $15,000, $32,000, $37,000. Which drug creates the most savings? Drug C, right? If you just look at the savings, so that's all we hear is savings, savings, savings. But if you're a self-insured employer, drug A, you're going to pay $15,000. drug B, $32,000, and drug C. What if you're the employer and you didn't even know that drug A existed? I have an ERISA attorney that has given me lists of drugs that self-insured employers have on their formularies, and they don't even know about the lowest. So that's where education comes in. And that's one of the things that we're going to be talking about today. And then what about the fees? Well, the fees are also a percent of the list price of the drug. One of the big PBM reform bills in Congress right now is delinking the fees from PBM compensation. We shouldn't have a perverse incentive to choose a higher priced drug. I don't care what kind of savings you're talking about. That first drug A, they could give a 100% rebate and couldn't create the savings that the $75,000 a month. It's pretty simple. Everyone says it's complicated. So I'm just going to give you a little example of what's hidden behind the scenes. This kind of information, I'm going to walk you through it, is never really found out. Kaleo is a drug company that made a Narcan pen called Evzio. And the only reason we even have these numbers is they countersued each other years ago. Kaleo countersued Express Scripts countersued Kaleo. And so through Discover, we found this out. So Kaleo's price for their drug was $900 or thereabouts in January of 2016. And the formulary rebate was $1,600. The administration fee was $24,000. Price protection rebate, that's if you raise the price of the drug, the payer gets more money. In April of 2016, they raised the price of the drug to $4,600. Sure enough, that commercial rebate went up. Look what happened to the admin fee. Look what happened to the price protection rebate. Do you think employers know about that price protection rebate? Many of them don't. And in fact, there's fine print. So there's more education and more transparency that's needed, clearly. So we're going to move on from this. Let this sort of settle in your mind in terms if you're a self-insured employer. It's one of the things that they need is education. So we're going to move over to mandated white bagging and then accumulators and maximizers. And I'm going to let Nilsa take over.
Thank you. Can you show me? The slides? Okay. Hello, everyone. My name is Nilsa Cruz. I'm from Puerto Rico, so the accent is very much Spanish. I have been a practice administrator at the Milwaukee Rheumatology Center for over 25 years, and also a patient advocate. The rheumatologist I work for happens to be my husband, Dr. Daniel Rossler. And today I'm here to talk about white bagging, mandated white bagging. I have a question for all of you, and we all have been in that situation before. Who in this room does not know what white bag is? Wow. Thank you for your honesty. So pretty much the process of white bagging is when physicians who are buying and billing for physician-administered drugs under the direct supervision in their infusion suites are no longer able to do that. The reason being is the third-party administrator, and notice how I didn't say payer, because they pay for nothing. They are a third-party administrator for the employer groups. They pretty much mandate that these benefits moved from the medical side of the buy and bill into the pharmacy side. And there are a couple of reasons for that. One of them is that they go to employer groups and they say, do you realize that these doctors are making money on the drugs that are being infused in their suites? That's one. And number two, which is really a pretty much good reason, they want to bring all these benefits into what they call more transparency. So they bring them over into all one single platform where they can actually keep track of not only the drugs that are being administered by the physicians, but also your self-injectables and your orals. The PBMs, and this is what they fail to tell the employer groups, they collect all kinds of fees and all kinds of rebates. They are steering these patients to their own specialty pharmacies, and obviously is adding more money to their coffers. So, is this move really saving employers and pretty much the healthcare system dollars? Maybe when it comes to hospitals. We all know that hospitals tend to be a little bit more expensive, right, than physicians' offices. About 4 to 5 times more they charge for these medications. But if you look at the 100 most expensive hospitals in the nation, you could actually see charges up to 10 to 18 times the cost of drugs. Typically, savings are really achieved at the physician suite, under buy and bill. And right now I would like to give you a real white bag example. If I have time, I'll give you 2. And this literally happened to my office. According to the Consolidated Appropriation Act of 2021, big words in there, and Dr. Maddie will be talking more about it in a little bit. It is abbreviated CAA. It's a great law that mandates claim transparency. Transparency from the employer groups to the health plan, transparency from the health plan to the employer groups, transparency from the employer to the employees. So back in 2021, we had a patient that was actually mandated to white bag by, the employer was actually a 530,000 employee group, out of which about 450,000 of them were based in the United States. The rest were in the rest of the world. So white bagging back in 2021, it was very difficult for myself and for the patient to actually obtain the receipt, even though that law, the CAA, mandate all kinds of transparency. But the patient was able to actually obtain the actual receipt of the charges to the plan for the treatment. And in 1 year, it came out to be a little over $43,000. The employee, the cost to the employee was $525. I died and went to heaven because I already knew that I could do it a whole lot cheaper for that mega employer group. And I decided to pursue an exception to their pharmacy mandate. So that happened in 2022, and under buy and bill, I was able to do the exact same services for a little over $12,000. Think about this, guys. $43,000 versus $12,000. And the cost to the employee was $30. This is huge. I do have to tell you that for 2023, I decided to pursue another exception, now based on the fact that I have the receipt from 2021 and my receipt from 2022. I mean, who would not go for cheap, right? Turns out that the third-party administrator, remember? You guys call it payers, they pay for nothing. The third-party administrator felt that they were not going to approve another exception, and they actually told me, and I quote, "Prepare to transition." These people really tick me off. I am transitioning no one, especially a patient who has been at the practice for over 20 years. So when they decided to ignore my love note signed by my physician, I contacted Dr. Feldman at the Coalition of State Rheumatology Organization. I knew about the CAA. I already knew, remember that pink slide that she presented, where according to ERISA attorney Paul Holmes, these plans are being overcharged by 30 to 40% on the pharmacy side? This was my proof. So I went to her and I said, I need CSRO's help. She very quickly wrote a letter, and it was sent to the CFO, CEO, and I think the HR?
Chief Compliance.
Yes. The chief compliance, and within a couple of days, I got my exception to the pharmacy side. When I contacted the third-party administrator, and I said, what did the committee, because it went to claims committee at the employer group, had to say about these discrepancies in prices? They went mute. There was no answer to that. I mean, that law is what is going to be able to get you this information. I have a second example for you, and this was a total disaster because it involved not only non-medical switch, but after we did the non-medical switch, patient had, it was mandated again to white bag. And this is a different employer. That division has 53,000 employees in the United States. So I decided to do the same little thing I did with this one, and I was hoping to get a whole year's worth of data. I never want anyone to come back and say, hey, this was probably a fluke. So I needed a whole year's worth of data. Problem here was that the patient did have one infusion. Then we scheduled the patient for the second infusion, and in between there was an office visit. Now, listen to this one. As you well know, things could change in between treatments. So the physician determined the patient treatment was now not being effective, but I had already ordered the white bag drug paid for in full by the employer at a tune of $10,426.78 for one treatment. I'm sitting on that drug. I cannot give it to another patient. There is no way that I can do anything with it but pretty much discard it. And this employer group actually paid $10,000 for it. If I would have been allowed to buy and bill, that medication would have cost the employer $4,224, savings of $6,202.78 per treatment. And this drug is being infused 6 times a year. So that was a total disaster. It begs the question, how does this affect the employer's fiduciary to its own employees, right? So other potential downsides of mandated white bagging could be delays of care. It takes time to coordinate this stuff, guys, as you well know. And the process is different. And if they send you the wrong medication, if they send you not enough vials, if the dosing changes in the middle of treatment, you're literally stuck. There's nothing you can do with that drug. You cannot give it to someone else. We talked about dosage change, wastage. I just gave you the example of the oops, I really, that's okay, I'm Puerto Rican, I'm allowed to do this, right? Right now I'm going to transfer it to my colleague Julie Bach, who has an outstanding presentation today for you guys. Thank you.
Thanks, Nelsa. Thanks, Dr. Feldman. My name is Julie Bach. I'm the practice manager of a mom and pop clinic called the Arthritis Center in Bridgeton, Missouri. My husband, Dr. Stephen Bach, has been a rheumatologist for 32 years. He came out of hospital-based employment and hung a shingle as a private practice 8 years ago. I had not had any experience in medicine or rheumatology before we opened this practice, so I am boots on the ground learning. I advocate one patient at a time, and I am the bathroom monitor, and I'm also the practice manager. So I love an advocate because we will do whatever it takes, one patient at a time. I want to briefly talk about accumulators and maximizers. Let's go. Oh no, oh no, oh no. How do we do this? There we go. Okay. So accumulators and maximizers, they're everywhere, but they're also banned in 19 states. We're not going to have any bans in St. Louis, Missouri, because it's the home of a large PBM that kind of has everything buttoned up in Missouri, but I will go down trying. I've actually testified at the Missouri Insurance and Banking Senate Committee before, and I've brought a patient with me, and it's very disheartening to be testifying with one patient, one advocate, and 9 lobbyists in suits against the other side. But I will go down trying. Accumulator adjustment programs and maximizer programs, they are at the core not good for patients. And of course, we're all wanting to get access for our patients, so why are we messing around with things that are not good for patients? Because they're good for somebody. Always follow the money, it always tells the real story. So they are manufacturer copay assistance cards that do not count towards the patient's deductible. In our practice, we serve the working class folks, and my patients don't have another $60 copay or another anything. We try to do it all, so when we have these maximizer or accumulator levers, and these patients can't get their drugs, it's a really bad thing for the patient. Okay, so for maximizers and accumulators, for the PBM, the pharmacy benefit managers, the maximizers are more popular right now. The accumulators have that bad public relations because the patients lose access mid-year to their drug because all of the copay assistance are stolen off the card mid-year. So this is less popular right now. But the maximizers, this is where you really follow the money. They extract even more money from the copay cards, and there's not the bad public relations. So that seems to be a lever that the PBMs and some of the insurance companies are really pushing. So for the self-funded employers, they are desperate to save money. As a rheumatologist's office, I have a huge target on my back because of the price of the drugs we prescribe, infused sub-Q injections or the oral medicines. And the self-funded employers are like, oh my God, we've got to control the spending. But the PBMs, for maximizers and accumulators, this actually makes them more money. So the self-funded employers, they're not educated. They don't know what questions to ask because they're coming to the PBM saying, how can we save money? And then they're saying, okay, well here, you got to choose this lever or this lever. And if you don't, it's going to cost you more money. There's not that transparency. So it actually harms the employees, the beneficiaries, the patients, monetarily and physically. J&J is actually suing Save on SP, which is a maximizer accumulator plan. 19 states have banned accumulators already. Problems with accumulators and maximizers. They're essentially stealing the assistance from the patients. That's what it is at its core. Employers can be charged twice. So we already saw the examples from Dr. Feldman and from Nilsa about these incredibly high fees. But with these little levers, the PBM charges the employer twice by the maximizers. It leads to increased out-of-pocket costs for the employees, the patients. We saw the examples from Nilsa, how the patient had a $30 copay for her office and a $525 copay for the same administration of the same drug when it was mandated to white bag. It leads to decreased adherence, delayed screenings. It leads to absenteeism, hospitalization, short-term disability, workman's comp, long-term costs, decreased productivity, every single thing the employer doesn't want. But they don't even know what they don't know. This is why we do what we do. It also disproportionately harms the patients with the high deductibles, who are often the financially disadvantaged and chronic diseases. So what we do every day to get up and going is, what can I do to keep this patient on therapy? This is discriminatory, these two levers. I'm going to turn it back over to Dr. Feldman.
Real quick story. The chief medical officer of one of the large PBMs, about 2017, was going to the Yale rheumatology section, and I had given a talk at American College of Rheumatology on copay and maximizers. They were kind of new at that time, and one of the fellows was going to be a faculty there, and they said, do you have any questions? And I said, yes, ask them if they're going to employ a copay accumulator in their plan. And essentially what the CMD said was, patients who have high deductible plans, they pay a very low premium and essentially do not deserve to have their deductible covered. When do we have payers deciding what patients deserve and what they don't deserve? Okay, I had to tell that story because it still chokes me up. We're not going to talk about alternative funders. Does anybody here not know what an alternative funder is? Well, tomorrow, Nilsa and Julie will be talking about them. It's a new kid on the block with self-insured employers to basically uninsure all specialty drugs, and then they come in, save the day, get them for free, basically draining patient assistance from many of the assistance funds that are here. So these are just some of the names if you come across them. Tomorrow you're going to learn a lot more. We're going to close with the conflicted consultant, and this is probably the most important thing for the self-insured employers. I'm lifting a number of, most of the information comes from slides from Michael Thompson and Paul Holmes, a webinar they did for the National Alliance of Healthcare Purchasers. So back to the Consolidated Appropriations Act. A lot of these lawsuits that you're seeing now has to do with the mandated transparency of claims. And the payers, the third-party administrators are saying, we don't have to give it to you granularly. The employers need that granular information in order to basically follow the law. So they disagree on this granularity. And Section 202, that's where the consultants come in. I'm going to show you some numbers in terms of how much employer benefit consultants are paid. I'm not saying all employer consultants are bad. I had one that alerted their employer to a $10,000 metastatic prostate cancer drug that was on the formulary, but the $350 generic was excluded. So many of them are very helpful, but there's a lot that aren't. And Section 202 allows the employer to demand from their consultant in specificity, how much is the PBM paying you? How much is the health plan paying you? Because they know how much they're paying. So let's take a look at it. If you have a plan size of 5,000 employees, annual PBM referral fees are somewhere between $100,000 and $200,000 to the consultant. If you've got a plan, if you've got over 20,000 employees, $1 million to $1.5 million. So who's paying the consultant more? The employer or who they're supposed to be sort of helping them with? And it results in a conflicted consultant. So if employers take nothing away from this, the main thing is to find out and make sure you have a consultant that actually is on your side. These are a couple of the things that these conflicted consultants do. They don't even challenge the profit centers from some of the third-party administrators. They don't tell the employer that there's a lower-priced drug. They delay or block in the contract any generics or biosimilars. Paul Holmes told me a story of a 350,000 employee company that spends $50 million a year on Humira. And the consultant has already told them, don't switch over to the biosimilar. They would save $40 million. So this is why we're saying there are things that self-employed self-insured employers can do that will help them not break the bank. They hide rebates and rebate aggregators that are offshore, and they don't reveal, as Nilsa said, the true cost of white bagging. Now, in every case, is it going to be that much less? Perhaps not. But the Consolidated Appropriations Act allows the physician as well as the TPAs to compare prices. You saw that price protection rebate of $5 million. Oftentimes in the contract, in the fine print, the price protection rebate is kept by the TPA, not the self-insured employer. Oftentimes promises are mysteriously gone. They go, you don't need to audit. That's not important. We don't have to do that. That's a waste of time. And because fees are kept by the third-party administrator, oftentimes rebates that are promised to the employers are reclassified as fees. The bottom line is employers need to make sure that their consultant is on their side, and that's probably one of the biggest takeaways from this talk. I think it lets us know why they're paying 30 to 40% more. All of this boils down to the employees perhaps not getting the kind of care they need because employers are trying to save every dime. Again, if you're in a self-insured employer, remember, you can sue the plan if they don't give you the kind of information that you need. So some final action items. Education is probably the biggest thing for employers. And as I said, we have started an employer toolkit from the Coalition of State Rheumatology Organizations. Consider the effect of maximizers. I had a patient, a maximizer was put into her plan, and that year, because of that, her husband couldn't go get his screening colonoscopy that had been due the year before. They counted on that deductible being filled so they could get screening tests. Make sure you see all of the proposals from the smaller PBMs, get a non-conflicted consultant, and be sure to also hire an attorney, an ERISA attorney that's not only familiar with contracts, but a lot of the shenanigans that happen with pharmacies, whether definitions of what's a specialty drug. And I know we're probably going over a little bit, so education and transparency is probably the most important thing for employers. And let's never forget that the public's desire for transparency has to be balanced by our need for concealment. Thank you so much.